schedule it during my work time? I can't help.
Okay,
Hi.
here we are.
I'm sorry. I don't know why that happened, but it's working now,
That,
so that's
that's
good.
fine, Amanda. So we need to wait a few minutes
That's
because
fine.
the people was expecting a live in my account, so now they need to migrate to this account. But I can see already some familiar numbers and faces.
Yep.
So again, thank you everybody to be back with us. I have started this live 3 times now.
I'm so sorry.
That's fine. That's fine, Amanda. Thank you for being with us today. People is connecting little by little.
Yes.
And I told my students that this is a mandatory lecture. So text your mates, put it on the Facebook group so everybody joins and connect with us today.
Thank you.
Amanda, thank you so much. I know that it's early morning for you in the other part of the world. Here is 7:22 p.m. What time is for you?
It's about 8 a.m. in the morning.
Oh, very early. Okay. I put in the post that you were sacrificing your sleep hours to be here with us, so people feel like, oh, and they connect. So let me introduce you to the people that doesn't know you. Actually, I don't know you that well. And Amanda and I have been in a couple of events together, but I know her because of her social media, because she is very social media savvy. She has a very active Instagram account, and she even has a YouTube channel that is very educational, a lot of information about oral medicine, and she will tell us a little bit about her interest in orofacial pain and temporomandibular disorders. So without further ado, Amanda, she is an oral medicine specialist from the University of Western Australia. She has a private practice and she also has a faculty appointment. Am I right? You have a faculty appointment? Good.
Yeah.
At the University of Western Australia. And as I say, she is very active in social media. She has a YouTube channel and she has a particular interest in temporomandibular disorders or facial pain. Thank you, Amanda, for being here with us today.
Thank you very much. Thank you for having me. And I'm really sorry about I don't know what happened there. So
That's fine.
even though I'm social media savvy, I guess I'm not that savvy.
Well, that happens to everybody. That's the way it is, technology.
Yeah. Yeah.
So
So
Amanda, tell us a little bit about your interest in temporomandibular disorders, and is this kind of a specialty of dentistry in Australia? Is considered a dental specialty or a facial pain there?
it is. So we work in a multidisciplinary fashion usually. How's my audio? Can you hear me okay?
I can hear you well.
Okay, great. So we usually work in a multidisciplinary setting because, as you know, oral facial pain, we usually sometimes will have to work with a psychologist, psychiatrist, physiotherapist. So we have multidisciplinary pain management clinics. Depending on which part of Australia you're in, sometimes it will be handled via a medical specialty or a dental specialty. There was a little bit of a need for oral facial pain to be seen via a dental specialty, such as oral medicine, is because doctors are not necessarily trained in looking at the difference between odontogenic and non-odontogenic pain. So having someone with a dental background is quite useful because, as you know, dental pain and temporomandibular joint pain, other forms of oral facial pain, have very similar clinical presentations. So the way we work here is that we see pain patients in oral medicine and we work closely with other specialties and other disciplines.
So you have all the specialists in the same physical space, in the same clinic. Do you have a physical therapist and a psychologist?
So ideally, but everywhere is a little bit different. So in private practice, we work quite closely with a physiotherapist and a psychologist in the same area. In the hospital, in the pain clinic, they've got physiotherapy, they've got they've got psychiatry, they've got actual pain physicians with a medical background, they've got so it depends on where you work, but generally, even if they're not physically in the same building, they would have pretty close relationships with other people in the same department.
And Andres is saying hello to you. or I believe.
I,
So
how did you tell everyone to join here?
they can see that I have a live, so they need to migrate little by little.
I get
Every
it.
time that I start a live, my followers will get a notification and people join. So Amanda, let's start because we have now 50 minutes to talk about this fascinating and pretty extensive topic.
Yeah.
So tell us, what did you prepare for us today?
So I actually prepared a few things because I thought it would be quite interesting to go through the basics of temporomandibular disorder. It's such a broad topic with so much overlap. But the first thing that I thought would be very useful for people to know is the diagnostic criteria of temporomandibular disorder. So it's the DCTMD, and the reference to that is Schiffman 2014, and you can actually Google it and find it online. So if anyone that is treating temporomandibular disorders, I feel that the DCTMD is a very good start because it covers screening. So I don't know if people are screening their patients as they come through for jaw pain, but because jaw pain is quite prevalent, there is a very simple screening technique, which I quite like. So this is slightly different from the DCTMD, but this is so simple that I think anyone can do it. Oh, it's flipped the other way around.
Yeah.
It's called the three.
You can read it.
Yes. So it's called the 3Q TMD, and the reference is Lovegren in 2018. And it's only 3 questions that you ask patients, and it gives you a good idea if they do have temporomandibular joint disorder or not. So it's not necessarily good for excluding patients, but it's pretty good at giving you an idea if it needs to be followed on or not. So the 3Q TMD, the 3 questions are basically, have you got pain in your temple, jaw, or jaw joint once a week or more? The other one is, have you got pain on moving your mouth or chewing once a week or more? And the last one is, does your jaw get locked or stuck once a week or more? So I think maybe a simple thing that people can take away from this is screening your patients. So the 3Q TMD is only 3 questions. It'll take you a couple minutes. We'll give you a good idea if you need to carry on asking further questions along the line or not. When someone is suspected of having temporomandibular joint disorder, what I would probably suggest is that as part of your oral examination, to do a simple TMD examination. It doesn't have to be overly complicated. One of the really good things about TMD or about muscular pain is that pain on palpation is actually a really good sign. So if you touch someone's muscles, and it is painful on touch, that's generally a pretty good indication that they do have muscular pain. So the muscles that you do want to palpate, and I've got my little friend over here.
Yay.
Yes. The muscles that you want to palpate is the temporalis. Now, the temporalis is a big fan-shaped muscle, and it has 3 broad portions, so anterior, medial, and posterior. You can't really miss the temporalis because it's so big. If you are unsure of where the temporalis is, all you basically do is put your hands in the area, get the patient to clench, and you can actually feel it bulge. So touching the temporalis is a good one. Masseter's, obviously, it's the one where they clench, you can feel it bulge. And medial pterygoid. So medial pterygoid is the one that you can see intraorally here. So if you go to the anterior border of the ramus and go a bit posterior, that's pretty good for the medial pterygoid. Now, one thing that it comes up in the literature every so often is some people talk about palpating the lateral pterygoid muscle. It's almost impossible to palpate it directly. So the way I get to check if there is pain with the lateral pterygoid is with functional manipulation. So you get the patient to open against pressure, and if there is pain, or if you push back and they try to open and there's pain, that may be the lateral pterygoid muscle. So I wouldn't try to palpate that one. That's pretty impossible. But the medial pterygoid is pretty good, which is that one there.
So do you have any particular technique or any reference to people that it's not familiar with the palpation of the medial pterygoid, how to do it?
So
what reference can they use? What teeth can they follow? Or
yeah, so basically you can go just posterior to the occlusal plane. So exactly like how you're giving a mandibular nerve block, you actually go through the medial pterygoid if you're giving a nerve block. So if you just pretend like you're giving them a block and you palpate in that area. One of the things that I noticed that when I teach people how to do a temporomandibular joint examination is that they don't palpate hard enough. So sometimes you get that, oh, is that painful? Is that painful? That's not really accurate. So you do have to palpate with enough force So if it's something like the medial pterygoid, about 0.5 of a kilo is enough to palpate. Outside, you probably want to palpate about a kilo, about 1 kilo of pressure. And a good way to do that is that if you are friendly with your local supermarket, you can actually go there and use the scales that you use to weigh your fruits and bananas to actually see what half a kilo and 1 kilo is. So you do want to be palpating with quite firm pressure, and one side at a time, not both sides, to actually feel those muscles. So I think that that's a good thing to incorporate.
Here in America, we use pounds.
Oh.
So 2 to 3 pounds. So again, if you have those things to cook at home to weigh your food because you're super fitness,
yes.
You can go there. And most of the people is surprised that you actually need to apply a lot of force until you reach the 2 or 3 pounds of pressure. Other thing that I tell my students, they can get kind of a hard surface and press against the surface, and when they see that the tip of the finger blanches, that's pretty much, and they're like, wow, that's a lot. Yeah, that's a lot of pressure that you need to apply in the muscles.
It is. So sometimes, even when palpating myself, because I don't have muscle pain at the moment, but sometimes even when palpating my own medial pterygoid, I can feel a little bit of like mild discomfort. So it should not be, you don't want to hurt your patient, but it shouldn't be too comfortable for them, if that makes sense. So I think the muscle palpation is a good one. The joint, so opening and closing, hearing for clicks and crepitus. Another good one that I like to see is if there's actually deviation or deflection. So prepare this one here. So deviation is when someone opens their mouth and there's a deviation, it goes back to midline. So it opens like that. Deflection is straight to one side or not. That sort of gives you an idea what's happening in the jaw joint, because the deviation that happens is as you first try to open your mouth, there's about 25 millimeters of pure rotation. So the first 25 millimeters when you open your mouth, you don't usually hear a click or anything because that's when the jaw is just rotating. As you try to open further, it actually translates forward. And that's when, if there's any internal derangements of the disc, that's when you can feel it. So the deviation is basically the jaw opening first as it rotates, and then it hits the disc that may be displaced. It overcomes the disc and goes back to the middle. If you get a disc displacement without reduction, that's when you may get the deflection because one side is basically not opening correctly. I don't know if you can see this. How does that look? Can you see it?
I can see it.
Yes. So that's the disc there. So it's a biconcave disc. So it's thinner in the middle. And then what happens as it slides forward is that as you try to open the jaw joint, it rotates, the disc is slipped forward. And the click that people hear is where the jaw joint goes back, the condyle goes back on the displaced disc. So you open and then you open and close. Now, when you don't hear a click and when there's a limitation in mouth opening, for example, that's where the joint is not able to get back on the disc and the disc is more permanently placed. So I think that's a good thing. So that's the basic of disc displacement with reduction and disc displacement without reduction. Reduction without reduction means that there's generally no clicking. Disc displacement without reduction and with reduction, I suppose, can also be associated with intermittent jaw locking. Yeah, and it can also be associated with a limitation in mouth opening. So even if you stand in front of your patient after you've felt everything and get them to open and close their mouth, see how wide they can. One of my useful tips, I think, with mouth opening is that if you have a ruler, you can get them to open and see how wide they're opening. If you don't have a ruler, so for example, if you're stuck in a country location or if you're locuming somewhere and they don't have any of these, actually using fingers are a pretty good indication. So a finger is about 1 centimeter. So you probably want them to open about 3 or 4 fingers wide. And that's probably about a normal opening as a rough guide. But so when you use the ruler to measure the maximal mouth opening, one of the good things that I like to check, if it is less than 40 millimeters, is to actually see if it's a soft or a hard end feel. So a soft or hard end feel means, can you stretch it any further beyond what it is? So sometimes you get them to open and they open like, can you open any wider? And then you can see there's a passive stretch, they can. Now, if you open it, you find that there's a hard end feel. So if you open and it feels like there's an obstruction, that's something that I think needs to be investigated further.
Okay, so Amanda, as a summary, so you were saying that you pretty much screen all your patients to determine whether or not they have temporomandibular disorders. And to do that, you use the screening tool from the DCTMD. It's super easy. It's just 3 questions and asking about clicking, pain, and
Locking.
limitation of mouth opening.
Yeah.
And locking.
Yes.
Now, then you talk about how important is the clinical exam. The clinical exam is going to be the part of the examination of the consultation that is going to give you all the information that you need in order to come up with a diagnosis. So you talk about the muscle palpation, the different muscle of mastications, and how to palpate them, and then you talk about how to assess the TMJ per se, like palpating, placing your fingers, asking the patient to open and close to determine if the patient has deviations or deflections, and you already talked about those. So I think it's important because people is not super familiar, some people is not super familiar with temporomandibular disorders to differentiate muscular diagnosis, muscular pain, muscular complaints for articular TMJ per se complaints. So how do you do this?
Yeah, so the DCTMD actually, so one of the things, the DCTMD does have a screening questionnaire. It's slightly longer than 3 questions. So the one that I would recommend that dentists do, whichever is easier. I find that the 3Q-TMD is something that as part of a general dentist doing their examination, they can ask really easily. The 3Q-TMD, the DCTMD one is slightly longer. So how to differentiate between muscular and joint pathology? The DCTMD has very good diagnostic trees that will help you differentiate between the two. In my experience, I find that with temporomandibular joint disorders, it is more than often a combination of both. So when you check the patient's jaw joint, you can get clicking and crepitus. So that is usually a pretty good sign that there is joint pathology of some sort. Crepitus is very good for something like osteoarthritis where there's breakdown of the jaw. Clicking is pretty good for a derangement. But the thing is that about 30 to 40% of the population have clicking of the jaw joint anyway, and it doesn't cause them any pain. So we don't treat those patients. So that's also another one. So if you notice a patient and they're not really in any pain or discomfort, I would just note it in the examination. They might not necessarily need any treatment. So muscle pain, very good to palpate muscles. One of the good things, one of the nice things about the muscles, as I said, is that if there's pain on palpation, it's generally a pretty good sign that they do have at least myalgia, which is local muscle soreness. You can get myofascial pain, where you get pain spread. So if the pain is not confined to the muscle for mastication, and you get it spreading to other areas, then you might want to consider a diagnosis of myofascial pain with spread or referral. Now, there are some muscles that have known referral patterns. So, for example, your neck muscles, they can actually refer up to your jaw joint area. So, your temporalis headache is a really good one. So, if you've got palpation with temporalis, ask patients if they're getting headaches. But I would also consider all of these diagnoses together, because it is not often that I see a chronic TMD patient without muscle soreness as well.
Can you describe the most typical complaint of a patient that comes to your office with muscular pain, whatever the diagnosis is? What they tell you? What are those red flags that can help the general dentist to think, oh, maybe this is not dental, this is coming from somewhere else?
Yes, okay. So if it's not dental, one of the big ones that I find with TMD is one of the good things in my head is whether the pain is nocturnal or not. So if the patient is sleeping, you ask them, does the pain wake you up at night? If the pain wakes them up at night, it is more likely to not be temporomandibular disorder. It could be odontogenic pain, it could be even trigeminal neuralgia doesn't wake you up at night. So that's a good one that I find. The other one is whether there is pain on hot or cold foods. So that's another good one that you might, if it's pain to hot and cold foods, check the teeth really well, because more than likely it is odontogenic. There are other things like neurovascular pain, for example, but for TMD, you're unlikely to to get those symptoms. The other thing that I find is very good is pain on provocation. So if you can elicit a familiar pain from the patient. So if the patient says, I come in and I get these headaches and my muscles are quite sore, if you palpate that and it's painful, that's generally a pretty good sign. Or they tell you like, I can't open my mouth very wide anymore. It's painful when I try to open much wider. Just get the patient to open up, and if they say, yep, that's the pain that I'm feeling, then that's also a pretty good indication, I feel.
Yeah, I ask you this question because sometimes the way that the patient express or manifests the pain is not super clear, and it can be very confusing for us to determine from where the pain comes from. And you were saying that the muscles has the ability to refer pain to different structures of the face and the neck. So there is actually referral patterns where the patient can feel pain on a tooth, and actually the pain doesn't have any dental source. The pain is coming from the muscle. So I have seen that the patients, the most common words they use to report muscular pain is dull, achy, constant pain. My face feels kind of heavy. So those are the most common complaints. Different situation when the patient reports dental pain is sharp, shooting pain when they bite down, nocturnal pain, exacerbated by hot or cold things. So those are important things that the dentist can use to help to differentiate the pain coming from one source to the other. Also, I always tell my students, take x-rays, percussion, bless you, and just rule out the most obvious thing that is dental pain. So when I was in dental school, any pain in the head and neck area is dental pain until proven otherwise. But if you rule out dental pain, it's muscular pain coming from the muscle of mastications until proven otherwise. Bless you.
Yeah, thank you. Yes, that is definitely true. We do see a few cases every so often where a patient has received a root canal treatment and the tooth may not have necessarily needed it, and the reason is the referral patterns. Basically, sometimes it can be very hard to tell them apart. But if you fall back on your diagnostic testing, sorry, I keep thinking I'm going to sneeze. No, I think I'm okay. So try to.
So, which ones are the muscle that most commonly refer to the teeth?
I think it's actually I think they all can refer to the teeth. I think, for example, your masseter can refer to your maxillary teeth pretty commonly, but I would not. I think the studies on the referral patterns, even though there are known referral patterns, they've not been able to standardize it very well. So I think the biggest one is that pain doesn't refer across the midline. So the referral patterns try to look at it left versus right. And I think within that area, if you've got TMD, because not commonly does someone have one muscle in isolation that's sore as well. So I would sort of consider it left versus right.
What I tell my student is like, although any muscle can refer to the teeth, it's very common that the temporalis refers to the upper and posteriors, more maxillary posteriors, and the masseter refers to the mandibular, also posteriors. And one of the things that they can do is to replicate the pain. And in order to do that, they need to apply the right amount of pressure for the right amount of time and be able to replicate the pain and ask the patient, this is the pain you feel? The patient may say yes or not. So when you replicate the pain, that's the best thing that you can do, and that's the best way to diagnose muscular pain. When you go to the gym and you are sore and someone touches your biceps, your triceps, you feel pain, you are sore because the pain is coming from your muscles. So that's my best advice.
I think if most people follow the rule of provocating the pain, replicating familiar pain, and asking a patient, is this the pain that you feel? I think that will help lower the incidence of misdiagnosis, for sure.
So it's very common for the patients to report pain on the face, as I told you. Dull, achy, constant, heavy, whatever. But what about when the muscles, the intraoral muscles, are affected? The pterygoids, lateral and medial pterygoids. What the patient reports?
So usually it would be something like pain chewing or pain on maximal opening. So they'll be like, every time I try to eat something, like they might tell you, I'm not able to eat steaks anymore. I'm not able to eat anything. Every time I open my mouth, it hurts, because the lateral pterygoid in particular is painful to functional manipulation. Every time you try to use these muscles, you generally report pain with jaw use.
So what is the most common cause for muscular pain?
What is the most cause for muscle?
Common cause etiology for pain of the masticatory muscles.
Yeah. So it can be anything from a protective co-contraction that has lasted a long time. So what I mean by that is, like for example, trauma. An example that people might be able to relate to is that if you go to visit a dentist and you have a high filling in the area, you stop biting on the area, because every time you bite on it, it hurts. It annoys the tooth. So you brace your muscles so you don't bite on that high filling. And if you leave that high filling in that area for 6 months, 3 months, you don't get it polished down, that protective co-contraction could eventually become myalgia. So I think looking at the purely what's the word for it? Looking at the purely muscular reasons, generally trauma, micro or macro trauma, bruxism, clenching. But obviously not everyone who clenches or grinds, or not everyone who has a high filling develops muscle pain in a chronic manner. So the psychosocial factors are very important as well. And with treating TMD, you've got to be very attuned and comfortable with looking at perpetuating psychosocial factors, which is why I think sometimes with treating these patients, you need the significant time to explore this history with them. So anxiety, depression, PTSD, chronic comorbid pain conditions as well, like fibromyalgia, irritable bowel syndrome, vulvodynia, non-specific back pain, non-specific headaches, like chronic TMD, very strong association with all of these as well.
Can you comment if you have any information, if you know anything about fibromyalgia and temporomandibular disorders?
Yes.
Fibromyalgia seems to be every day a more common diagnosis now. And what is the relationship of these chronic conditions, probably autoimmune, and temporomandibular disorders?
Yes, yeah. So one of my consultants, he actually studied at Penn State University. So he taught me, so he taught me that if the patient has fibromyalgia and temporomandibular disorder, chronic temporomandibular disorder, they don't have temporomandibular disorder, they have fibromyalgia. Everything's painful. So one of the concepts that I think that I like to explain to patients is a concept of central sensitization. So your body's system, so your brain and your spinal cord, are primed to respond to pain. So you feel pain easier because you don't have as high a threshold. So basically your body is sensitive to pain. So I think a lot of these patients, if you explain to them that they have, because they've suffered from chronic pain for years, if you tell them that the pain that they're feeling is an extension of some of these bodily symptoms that they have in other areas, they tend to understand that. One of the things that I have here, which I think is really good, is a central sensitivity mark sheet. So I'll read this out. Sorry, I know you can't really see it. But some of the comorbid conditions is restless leg syndrome, chronic fatigue, fibromyalgia, migraine or tension headaches, irritable bowel syndrome, multiple chemical activities, whiplash is one. I think whiplash is more related to trauma, but that could be a whole thing. Anxiety and panic attacks, depression. One of the other things that I find in my fibromyalgia or chronic pain patients is that sometimes they have a disability. Sometimes they have an insurance claim for disability. I'm not saying that they're it up. I'm not saying that they don't deserve disability payments or anything like that, but it is a secondary gain sometimes for these patients, unconsciously or consciously. So I think we need to consider it as a whole, because people with fibromyalgia or with other disabilities, they may not be working as well. And we know the association with not working, not having financial stability, not having a support system, that all plays into the chronic state as well. So it's really like a whole situation.
Yeah.
patients.
Amanda, I really like that picture, that table that you show, and I'm going to ask you to take a picture, send it to me, and I will post it on the, so people have a list
This
of the
one?
conditions.
Oh yeah,
Yeah.
I will.
Yeah, so they can ask their patient, they can inquire about those conditions, because actually you mentioned a couple of conditions that I wasn't aware that are related to chronic pain. So I think we covered pretty well muscular pain. So now let's talk about TMJ per se. You were talking about clicking, popping, and crepitus. So, and you said that these conditions are asymptomatic, we don't really treat it, and you already explained what happened, that the disc is anterior to this displacement. What happened when the patient has any of these clicking, popping, or crepitus that is actually associated with pain?
So sorry, I didn't realize that all of my diagrams will be back to front. So I might send you this one as well. So what I do with these patients is, after I see them and I examine them, and we come up with a diagnosis. So the diagnosis most commonly is a displacement with or without reduction, and then with or without reduction, and then with or without locking, or sorry, I got distracted by the questions below.
I told you, don't pay attention to the questions, that I will read the questions to you later.
I know, sorry. So yes, so once I reach the diagnosis, whether it's muscular and joint or either or, we then come up with a treatment plan that's targeted towards it. Now, imaging is something that's quite useful. So if you find that the patient's a little bit atypical, or they're not getting better even with conservative treatment, then what I will probably recommend is some imaging. So the MRI, the magnetic resonance imaging, I find it the most specific for actually seeing the articular disc on MRI. So imaging is something that I would consider. And I would always start the patients with basic conservative therapy first. The evidence does show that if you do surgical management of temporomandibular joint disorders, their long-term results are not necessarily better than managing them with conservative therapy. So say exercises in splints. The exception is if they have clear pathology that needs to be fixed surgically, then of course I'll refer them to a surgeon.
Sorry, I got distracted also reading the questions and taking notes to ask you later. So you order an MRI to every single patient that comes to your office and reports clicking? No, right?
No. Not every patient. So if there's something that's a little bit unusual, so if it's not a straightforward thing, there's any question of their diagnosis, or if you have managed them and they are not getting better, I think it's recording it, but not everyone.
What about patients that reports to you changes in the occlusion? Open anterior, open bites, posterior open bites, and shifting. Yes. What we need to consider when a patient reports any of those?
Yeah. So if it's first I would look and see if unilateral or bilateral. If it's a bilateral open bite of any kind, I will order imaging. One of the things that can happen in a young child, maybe, or a younger child, idiopathic condylar resorption. So what can happen is that sometimes they have malformed condyles, or basically they're not formed properly. And what can happen with that is that if you have the condyles are not formed properly, you notice they have an anterior open bite forming. So that one, I would want some imaging. With the posterior bite, whether unilateral or bilateral is another thing I'll consider, because what can happen, you can get inflammation of the tissues behind the disc. So you can get retrodiscitis, capsulitis, or synovitis in the area. You get inflammation. And then what can happen is that they can have a posterior open bite and then a heavy, heavy contralateral canine occlusion. So that's one of the things that I would look for. In terms of the shifting, I would consider deflection or deviation first as the most common.
Okay, and deflection and deviation is related to muscular rather than articular?
Usually internal derangement. It can be muscular. Okay. It can be muscular, but from what I know, if I see a patient with deflection, I would usually consider joint rather than muscular. You can get limitation in mouth opening, or you can get patients who have muscular fibrosis, for example. But I think I would consider joint pathology as more likely rather than muscular, even though I would obviously consider both.
Okay. What do you think? What role plays occlusion in temporomandibular disorders. And I'm asking this question because it's pretty common to see some dentists that every time they do any rehabilitation, they always fabricate our occlusal appliance, and they do the occlusal appliance in centric occlusion. There are new devices that measure the forces, and they have occlusal adjustment. What do you think about that?
I think the studies are very clear, and I guess it's a worldwide problem. You shouldn't be doing occlusal adjustment or equilibration for the treatment of bruxism or TMD. Like the studies are just not there. Studies were there in the 1960s, but we've come so far since then. I just don't think that there's a reason to do it. And just don't do it.
I agree with you. We don't have enough evidence that occlusion plays any significant role in temporomandibular disorders. So I never recommend playing with the occlusion, because that's the beginning of a nightmare.
Yes, and plus
so,
it's irreversible as well.
Is what?
It's irreversible. So you are subjecting patients to all of these treatments that cost money, they're irreversible, and in most cases they don't work. Because if everybody who has malocclusion has TMD, then we will be seeing so much more TMD. Because, you know, everyone's teeth, most people's teeth are not straight anyway to begin with.
Yeah. So we have pretty limited time here. I think that we should talk about treatment.
Okay, yeah. So in terms of the treatment, it's holistic. So it's not just one thing. So what I see some dentists or some students do is they give a patient a split, and then they never see the patient again. It has to be combined. So the psychosocial is very important. I think people who want to treat temporomandibular disorders have to be very comfortable at exploring that, because if your patient has psychosocial factors, that affect their prognosis. So the first thing that I do is education reassurance, explaining to the patients what their diagnosis is, and discuss with them, like, you know, usually temporomandibular disorders is a musculoskeletal problem. It does get better. So the explanation and reassurance, I think, is very important. Avoiding other factors that they can control. So identifying any habits, nail biting, gum chewing, pen biting, chin resting, you know, we discuss all of that with them. One thing that I do ask school-aged children is if they are playing any music instruments that require the jaw, because I'm actually quite surprised. In Australia, quite a few of them play woodwind instruments. So I ask that, you know, saxophone and stuff, they can cause problems with the jaw. I put them on a little bit of a soft diet, so they don't have to have too much. But it just makes sense. If your jaw's painful, don't be eating anything overly painful.
For how long you keep the patient on liquid diet or soft diet?
So I tell them that they don't have to be excessive with it. So I actually keep them on it for a while until they start to feel better. I'm not overly restrictive, so I'm not saying that you only have to have soups or anything. But if there's anything that's causing pain, so if you've noticed that you bite into an apple, it causes pain. If you like to eat nuts or anything, like those things I tell you to avoid, you can blend it up and stuff like that. So I keep them on it for quite a while, but I don't make it overly restrictive. So I think it is quite adaptable. The other thing that I consider besides the home exercises is one, habit reversal, soft diet. So with the home exercises, it depends on what their diagnosis is, but generally, now the evidence, if you look in the literature for jaw exercises, is not high. Like, it's not something that people have been able to prove, but anecdotally, I find that giving my patients some jaw exercise does help, especially with muscle soreness. So I get them to do a stretch. We get them to put their tongue in the N position. So tongue behind the roof of the mouth to open as wide as possible and to hold that stretch. So it's a very simple exercise, but every time you do the jaw exercise, I feel that you are redirecting the pressure off the jaw joint. So you can't unload the jaw joint or anything like that, but I feel that you're just taking pressure off and you're stretching the muscles as well. So I get them to do the jaw exercise program. Sometimes we can consider medications if the patients do need it, particularly if they've got psychosocial history, if they have difficulty sleeping, stuff like that. Amitriptyline, pregabalin, some of those medications that we can consider. I think that should be done in a specialist setting only. I don't think general dentists should be doing that.
So you don't consider NSAIDs?
Oh, yes. Sorry. Yeah, of course. So before going to the stronger medications, you can consider simple analgesics like NSAIDs. If they have acute TMD, a short course of systemic corticosteroids may help as well. And then we also talk about the splints. So I've got a few splints here. I think the most important thing for maybe people to realize is that splints are not one size fits all. There are many different designs of splints, many different thickness of splints, many different materials as well. And I think that these splints have to be considered based on the patient's diagnosis. So just in general, this here is a stabilization splint or a plane splint. It is completely flat. Now, the evidence for this is the most, because it's the most studied type of splint. With a flat plane splint, there is very little risk of occlusal changes. So this is the one that I think most general dentists will feel comfortable giving. One of the smaller studies about a stabilization splint is that if it's in the maxilla and if it's thick enough, if the patient does have obstructive sleep apnea, it can actually make it worse. So that's one of the things about the maxillary stabilization splint, but generally it's very safe. And that's the one, that's the most common one. Everybody knows what this one is.
So how you fabricate those? Those are acrylic, clear, hard, flat, and that covers all the surfaces of the maxillary teeth, right?
Yes, that's it.
So what's the thickness that you order for those?
Yeah, so I usually go about 5 millimeters, but I don't feel like there's a lot of studies in that area. I generally go with about 5 millimeters for my splints. Now, if you are treating the patient for acute pain, there is some evidence that a thicker splint can help, but I do that for a posterior plane splint.
Okay,
Yeah.
Tell me something. When you deliver the occlusal appliance, how do you adjust it? What are you looking in the appliance? What you want to see when you put the articular paper?
Yeah, so I don't do any canine guidance or group function or anything like that. I just look for light, even contacts. So I get them to bite on the articulating paper. It looks all nice and even. There's no blue dots that are extra heavy, and even. That's it. That's all I look for the maxillary stabilization splint. I generally do hard because sometimes you can get a soft inner layer. I don't feel that the soft inner layer is useful at all unless the patient has a lot of pain. If the patient has a lot of pain and you want to give them a stabilization splint, having a soft layer inside can just make it a bit more comfortable for them to take in and put out. But generally, the hard splints are better.
You recommend those for the patient to use it at nights mostly?
If I have a few patients who are like anesthetists and things like that, so if they're crunching during work, they can wear it, but it's not practical for most people. So you can use it during the day. If you're going through a stressful period, if you're doing homework at home, you can, but generally it's at night.
So when do you fabricate lower ones, mandibular ones?
Yes. So even with the stabilization splint, I may consider a mandibular splint, depending on the patient's dentition as well. Sometimes they just don't have enough teeth in one arch or the other, so I'll go with the other one. The posterior plane splint is one that I like to do on the bottom teeth. So the posterior plane splint, if you have a look at it, is actually thicker at the back and thinner at the bottom. You can see like there's a little bit of a step in the area. Now, this is the one that I like to get it a little bit thicker at the back. The evidence of that is that if it's slightly thicker at the back, it takes, the patient does get more pain relief in the short term. So this one I can get them to wear it on the bottom. I like to use these for some internal derangement conditions. The lower splints I find, because one of the most common things I get asked is, oh, you're giving them a lower splint, isn't that going to be very uncomfortable? Actually, not really. So our splints are 3D printed, so they fit very well. And you can see it's not a big splint as well. It's not a thick splint. So it's actually fairly comfortable. So I like this splint. I find it well tolerated, and I find it good for pain relief. I suppose the important thing to preface this to say is that there's not a lot of evidence about what type of splints as well. A lot of times it's expert opinion or going by what other people find has worked. I don't know if you've experienced the same, but if you're looking for actual hard evidence, I don't think there's a lot.
No. Can you repeat to me, when do you fabricate the lower ones again? Sorry.
So generally, if the patient has muscular pain that is quite significant, if they have an internal derangement as well that is causing them significant pain, I like the posterior plane splint because I find that it is quicker with giving pain relief than a stabilization splint. But I must say that this is my personal opinion. I haven't found any studies that have said that. Yeah, so the other thing with the posterior plane splint I find is that I think patients find it easier to wear during the day than a maxillary stabilization splint. So what we've done with some of these splints before is that, you know how this part, the thinner part here, because they're not biting on that part, you can actually have a metal bar rather than
Yes.
that. And that one they can wear during the day. So if you have a patient, for example, with Parkinson's, a lot of clenching, a lot of grinding, they need to wear the splint very often. This is a lot more well tolerated than the other one, than the maxillary stabilization. The other one is a anterior repositioning split. So that one here, you can see it has a little tab. So it basically pulls your lower jaw forward when you wear it, and then that pulls the jaw forward slightly when you're wearing this. Now, with the anterior repo especially, the biggest risk of this splint is occlusion changes. So this is not a long-term splint. So after a while, once the patient gets better, we actually take the little tab down, and then they can use it as stabilization.
So you only fabricate these when the patient is on acute pain, especially articular pain. The patient needs to wear it for maybe 6 weeks, and then you change it, or what's your protocol for the anterior repositioning device?
Yeah. So the anterior repositioning device, it's probably the one that I make the least out of the others that I show you. I think for me, the indication for anterior repositioning split is if the patient has a lot of locking or loud jaw noises. One of the problems is that if the patient does have retrodiscal inflammation and you're pulling their lower jaw forward, that can actually make it worse. So that's one of the things that I do watch out for. So I think it's quite good if you want to alleviate locking and clicking, but I will be wary if the patient's having a lot of pain, especially if you can provocate the pain by moving the mandible forward, because that's just going to make it worse.
Correct me if I'm wrong, but I believe that the rationale behind that design is to kind of create more space so the disc can go back to the normal position, the retrodiscal tissue can go back to the normal position, and it's trying to kind of re-educate the muscles and the tendons to be where they have to be. Is that correct?
I think that's what some studies have said. I don't know if anyone's been able to actually prove that the disc can go back on the joint. I think what happens is that by redirecting pressure off that area, I think it promotes healing, so you can get a pseudo disc instead. So I think that's how I explain it to my patients anyway, because a lot of times they ask like, oh, can I just get surgery to pull the disc back onto the condyle? I'm like, well, no, actually, that you can't.
We are not in the 1990s now. They used to do that all the time in the 1990s and early 2000s, but we don't do that anymore. So let me ask you a couple of questions that regarding treatment. People were asking about physical therapy, TENS, acupuncture, dry needling, trigger points.
Yep.
When do you include these modalities in your treatment plan?
Yep. So I will include them if the patient does need it. So for example, for trigger point, especially if I can feel a trigger point, and trigger points are a little bit controversial. Not everyone believes in their existence. I have felt trigger points before, so I think trigger point injections can be useful. So if you can feel a muscle knot and if you press on it for a few seconds and you get the pain spread and referral, I think trigger point injections can be useful. I don't do acupuncture myself, but I've read some studies that actually have fairly good evidence for acupuncture. So I'm happy if the patient wants to do that. What were the other one? TENS, I don't use a lot of, but again, I'm aware that it is helpful for some patients. So I'm happy to explore all of these with patients if they need it. I start with this basic that I've described first, and then if they need additional pain relief, or if they're having breakthrough pain, then we discuss others. Like sometimes Botox for muscles of mastication, something that we can do. Low-level laser therapy can help with muscle pain as well. So there are things that we would discuss, but I don't do it as a blanket for all patients. I sort of only do it as they need it, and then I explore, the expectations, what they're happy to proceed with. Like, for example, with the laser, because it needs repeated treatment, some patients are just physically not able to come in, every week for a few weeks. And Botox is quite expensive, so sometimes they're not able to, afford the Botox in a few months. So we explore all of that with patients as needed.
So we have a couple of questions here. Someone was asking about your opinion of jaw exercises in patients with arthritis.
Yep, I think it can help, because the thing with arthritis, even though arthritis is joint pathology and you can get significant joint pathology, I don't think you can in a patient that's having pain, really separate the muscular component from the joint component. I think if you have bad arthritis, there will be some component of myogenous pain. So I think jaw exercises are useful, but I think the type of jaw exercises should be directed towards your specific presentation as well.
Someone was asking about if you ever use soft guards, occlusal appliance, soft occlusal appliance.
I do. So soft guards I find are the most useful for kids, because you can't give them a hard or a hard soft, because they're going to go out it very quickly. So generally soft guards I find are useful for children, especially when they're growing, because it's not practical to give them a hard splint. Some of the evidence shows that a soft guard can actually increase masticatory muscle activity. So I use those with caution, but I think there definitely is a place for it.
So I got very curious. You mentioned kids. What old are you? Do you introduce the guards? How old are your patients when you introduce the guards?
So it really depends. So I've done some work at the Children's Hospital here. We've treated patients, you know, from 6-7 years old all the way till, you know, 20, 30. So it's not something that we really like to do, but sometimes if they have hypermobility syndromes and, you know, if they've got significant psychosocial stress and stuff like that, if the kid is in pain, then we have to treat their jaw problems. So if they need a soft splint or if they need a splint, we do give it. Yeah, it's sometimes with
that I'm actually learning something, because here the way that I was trained, first we never order occlusal appliances for kids. No soft, no hard, no nothing, because they're growing.
Yes.
And whatever you put in the mouth for a long time, for prolonged time, every night for 8 hours, that kind of stop the growing of the jaw.
Yeah.
And the other rationale is that whatever that is soft is going to actually exacerbate and increase whatever habit. So, and I ask you also about the age, because during my residency, I only saw one 6 or 8 years old girl. Yeah. But most of the patients, and I believe this is consistent with the epidemiology, are 19, 21 years old girls, most of the cases. Yeah. But when they are considered adults, so you can actually fabricate. But I was surprised when you told me 6 years old. We never do appliances in kids.
It's not something that we'll do if we have another choice. But sometimes these kids, like jaw pain can be pretty bad. So if that's their only option, or if that's their easiest option, then that is something that we will do. Because
have you considered orthopedic appliances like flippers and things that the kids use? I don't know the names of those devices in English, but I remember that.
Yeah.
Retainers maybe.
We do, but it depends on their diagnosis as well. So sometimes if for example, if we see a kid with suspicion of obstructive sleep apnea, and if they have a very narrow maxilla, we would never do maxillary expansion to treat OSA. But if they have OSA, need maxillary expansion, then we'll refer them to the orthodontist for a consult. So we do, all of these kids in the Children's Hospital are discussed in a multidisciplinary setting as well. So lots of times there are multiple people involved. So, you know how I discuss sometimes syndromes and stuff like that. They've seen a pediatrician, genetic testing, rheumatology, and then sometimes if there are no other treatment options, or if they are in pain and they need help, then a soft splint is something that we will do. I do agree with you that it's not ideal, because there are side effects, especially if you give a hard splint that can restrict growth if they're transverse growth if they're in that sort of age. But if they have no other option, at least getting that short-term pain relief is a good idea. The other thing as well is that we do work with social services and psychologists as well in the Children's Hospital. So it's all part of a team. So all of the kids get discussed. So they've got like a plan. Surgeons.
Yeah, they understand that that's not permanent. It's just temporal until the symptoms resolve, and that's it. So did you ever use soft guards in adults?
I don't think I have.
And what is your opinion in the over-the-counter ones? Most of them are soft.
Don't.
So we have a very, We have a very good question here. I'm trying just to be quick because I know that we have like 5 minutes left.
Yeah.
Someone was asking about what is the mechanism for jaw exercises to actually help with pain.
Yeah.
What is the mechanism behind?
Yeah. So again, I think this is something that has not been definitely proven in the literature. There's a lot of hypotheses and there's a lot of theories. The way I explain it to my patients is that every time you're doing the jaw exercises, because I get them to do the jaw exercises very frequently during the day, I think it actually interrupts any clenching or bruxing that they might be doing. So I think in a pure and simple form, it actually stretches out the muscle. The other way that I explain it to my patient is that, you know how with the splint, we don't really know how splint works either, but it redirects pressure of the most painful part of the jaw joint. So by doing the muscle exercises, you are doing similar. So you're basically taking pressure off that area that the patient has been biting on to give it a little bit of a break. So I think it works both in helping to stretch out the muscles, it changes the way we process those signals, and it also physically redirects the pressure off the painful area. So that's how I explain to my patients why I want them to do the jaw exercises fairly frequently.
So what do you prefer, trigger point injections or dry needling?
For me, trigger point injections, but that could also be because I don't do a lot of dry needling. So it's obviously a biased opinion from me. The reason that I like the trigger point injections is that I think the fact that there's anesthesia in there gives them a bit of relief for longer. But
what local anesthetic do you use?
So we use a plain acetaminophen, so no adrenaline.
Yeah.
So that's what I use.
Good. So someone asked trigger points. We were talking about chronic conditions, and someone asked about chronic regional pain syndrome on the face. Andres asked if you have ever seen a patient with chronic regional pain syndrome on the face.
Yeah. We do. Usually part of the the multidisciplinary pain clinic. But yeah, I have. And with chronic regional pain syndrome, it's sympathetically maintained, so you can get flushing and swelling and redness of the face. This was the patient. This was a diagnosis that was done in a multidisciplinary setting. The patient also had CRPS of the hand.
Someone is asking here that it was a recent study that says that they fabricated a spleen and the patient has to wear it for a week or two, and then the patient is spleen free for a period of time, and the patient it goes back and forth in order to deprogram the muscles. What is your opinion in this concept of deprogramming the muscles, of re-educating the muscles?
I haven't read this specific study, so I'm not sure about this specific study. But in general, I don't actually believe that there's a lot of evidence for deprogramming or reprogramming muscles. But if the person wants to send that paper to me, I'm happy to have a read of it.
Yeah, this whole world of occlusal appliance is so, no one knows really what is doing. In some cases works, in some others don't work. So
I think
what I do, I always tell the patient, because here in America that's kind of an expensive appliance to fabricate, and I'm super upfront with the patients. 80% of the patients can find benefit, but there are also a 20% that never find that benefit. So if you're in that 20%, just sign here if you really want me to take the impressions.
Yes. The other thing about temporomandibular disorders I find is that it actually works in a cyclical manner. So patients can get better or get worse on their own as well, with or without, it happens like that. So if you treat the patient at the bottom of the curve as they start to get better, then everyone's going to get better. Obviously, it's hard to predict where on the cycle they are, but I think sometimes just because a patient gets better because you've given them a specific thing is not necessarily evidence.
Yeah. Well, Amanda, I think this is my last question. If people have questions, this is your last chance to ask all the questions. Are temporomandibular disorders preventable? Can we prevent temporomandibular disorders?
Oh, that's a good question. I think there is, that is a very good question. I think depending on, because temporomandibular disorders is an umbrella term. So I think there are certain specific diagnoses that have that. For example, some of the diagnoses that are related, for example, to trauma. Don't get hit in the face, then you may not develop acute TMD. So I think there's a little bit of that. But generally, I find